Radiotherapy is obviously an imminent part of a lot of cancer therapies. And as the whole cancer therapy pipeline, also we have a structured workflow. Starting with the initial consultation, the diagnosis has already been made, but we need to make a decision regarding the specific dose prescription we want to give to our patient alongside the specific fractionation. In order to then prepare for the treatment, there is imaging involved, here predominantly CT imaging, but we also use other imaging modalities such as PET or MR for better soft tissue contrast and more specific indications of the tumor extent. Based on this imaging, we then draw out the contours of our targets and the contours of the healthy structures, because radiation is given from the outside, so we predominantly talk here about external beam radiotherapy. So we need to make a plan of how we best balance the irradiation of the target, the tumor that we want to achieve, and sparing the surrounding healthy structures. And that means every patient actually already receives a personalized treatment plan in radiation oncology. We spatially adjust the dose for each patient on the given anatomy. This is historically a very technical process. We have a very close collaboration with our medical physics team. And I think that also means we're very prone to integrate AI solutions in this whole workflow because it's an optimization process already from the start. Once we have this plan, there is then QA involved so that we make sure that actually we will also be able to deliver this treatment as planned. Then there's the whole process of the treatment, which in our case also spans several independent fractions, ensuring alignment of the patient that we can actually deliver the plan as we intended to. And then, of course, as for every treatment, there is the follow-up. And then we'll also talk, of course, about how we would like to use follow-up information to go back to step 1 to improve our prescriptions from the get-go. So as you can see, there's actually a lot of applications of AI in radiation oncology. I've drawn them out here. I will try to talk about most of these aspects in a very short amount of time, but I do want to emphasize that this is really a range of different applications of AI. Some address really automation procedures, contouring, the planning process. Some are really for the delivery of the treatment, so time is really of the essence. And then there's the whole part of response prediction, where we also harness here multimodal data in order to improve the specific prescriptions for the patients, provide personalized predictions of response, and potentially also select the patients. So let's start by looking into what is the most mature part of AI in radiation oncology, and that is certainly the AI that is used to automate processes. We have been doing these contours for a long time already, and so we have a large amount of data in order to train this. And we already saw in the imaging-based predictions that contouring really is something that is very established now, deep neural networks, and of course this contouring at different levels. First of all, there is the contouring of the healthy structures, so organs at risk. And through this automation, we can actually ensure consistency in addition to speeding up these processes. And as I already mentioned, this is not something that is in the research domain anymore. This is really something that is commercially deployed. This is a nice dashboard that is provided by a website that summarizes the AI solutions in commercial products. And as of this Monday, we have 50 commercially available AI solutions for contouring in radiation oncology. Most of them regarding contouring of healthy structures. And actually here at INSA, we are also using an AI tool in this context already. But then, of course, there's also the tumor. And I did want to bring this comparison very briefly because we heard about the radiology department before. Contouring can be done on a tumor for response assessment. And of course, we also need response assessment in radiation oncology. However, even though we might rely on the same types of concepts of algorithms for the contouring that we use for planning, the evaluation metrics should be a little bit different in this context. For contouring in radiation oncology, small geometric errors actually could lead to very large dosimetric differences because, as I said, we try to target the dose to the tumor, meaning we have the strongest gradients actually in the very surroundings, so where the contours, the boundaries of these targets are. So we need to think about how to evaluate here really this geometric error, whereas in response assessment, it's more about the overall trajectory, where maybe smaller systematic deviations are more forgiving. And then let me talk a little bit more about our targets, because we do not just delineate what we see on the image. We do that too. That's our gross tumor volume. That's the first thing that is segmented. But actually, we also account in radiation oncology for the microscopic spread of the tumor. And since this is microscopic, we cannot see it on the imaging. And in order to account for that, of course, we need guidelines in terms of how we should extend the visible volume to what we would like to treat. And there is the Estro-EANO guidelines that actually recommend here isotropic expansions of these volumes, accounting for some anatomical barriers, but mostly that is done the same for every patient. And here actually AI can also come in by providing a better prediction of where microscopic infiltration is most likely to happen, to allow for a personalized map, first of all, of this infiltration, and therefore a personalized adaptations of target volumes. This here is a specific study where they actually developed such a deep learning model and then ran thereafter a clinical trial to assess the impact of such personalized target volumes on treatments. Moving on, I mean, this was just about the contouring part, so we are in step 2 of a 7-step process here. I did want to talk also a little bit about the other parts of automation, and that is both dose prediction and automated planning. And there is an important difference between these two. One is to provide you a realistic representation of what a plan could look like. And that is very useful because you can apply these models for counterfactual analysis. So how would things change if I have small changes to the prescription or changes to the contouring? And I could also assess, in the case a patient is present, do I actually need to adjust my treatment plan? Whereas the auto-planning, on the other hand, is really a full prediction of a deliverable plan. So here, really, the objective is, again, reducing the human interaction, improving consistency, and saving time. Of course, there's quite a difference in terms of how these two approaches are implemented. But again, both of these are actually also being rolled out commercially now, and we're also involved here in a clinical evaluation soon for such an auto-planning system. Why is automation so important? It is important because patients change. Patients change over time, hopefully in response to the treatments that we give in a positive way. But there can be changes also due to anatomical changes, different placements. And so adaptive workflows are really essential in our field of therapy. And here, effectively, by linking together all these automation steps, from the imaging to the contouring to the planning, we could arrive at a very shorter time window and therefore deliver also personally adapted treatments on the anatomy of the day. In this context, maybe you've also heard about MR-only workflows. This means that we're using imaging systems right on the day and also monitor the anatomy with this improved soft tissue contrast on the specific day. Of course, what this means is that we do not have the CT that is the basis for our dose calculation. And so here we need then generative models to generate synthetic CTs. And within Cairo, there's also a dedicated group from Professor Antje Knopf actually looking into aspects not from MR, but from cone beam CTs on how we could provide high quality CTs so that we could actually also move towards these adapted workflows. And lastly, also intrafraction motion management. If you think about it, the treatment may take a few minutes, you're still breathing, your heart is hopefully still beating in this time. We need to account for also moving targets in this context. So there's also dedicated AI for both tracking and gating to account for this motion. So to summarize this, in the automation domain, really the objective is to shorten the time, right? We want to reduce the human interaction so that we can account for the difficulties that we have in radiation oncology with moving targets either between or within the fractions that we're delivering. But what about this whole biology part, right? I think this is something I did not even touch upon yet. And of course, also for us, it is important to talk about how can we improve the response of our patients even further. And I wanted to bring this image because radiation oncology is actually quite well understood at the microscopic level all the way to the patient level. So it's a scale of biological complexity. And as I am running out of time, I will make it very quick to mention that yes, there are a lot of models out there, and we do have dedicated data types that we want to consider, such as the radiotherapy treatment plans. Data comes with some challenges, as any real-world data problem does, but of course there's a variety of different algorithms using multimodal data in risk prediction, in toxicity predictions, and also personalized outcome predictions. I will take 30 more seconds for my last slide because I think this is important and was not really addressed yet. This is about the QA of these AI tools. I mentioned we already have AI tools in the clinic, and so we also need to consistently ensure that they still do what they were trained to do. We need to ensure that they still generalize well, and also that our users still interact correctly with them. We heard this automation fatigue already, and actually now there are first commercial products coming up that assess, for example, the context of auto-segmentation and user interaction in this context, focusing here really on lifecycle management of these models, how we integrate human oversight efficiently, and how we can include also uncertainty quantification. So with this, I would like to conclude. I hope I could show you there is really a broad variety of things that we do with AI in radiation oncology, and I'm very happy to discuss more of that in the break. Thank you.